All right, it looks like we are at the top of the hour, so we're going to go ahead and get started with today's program. Good afternoon and welcome to the Immune Deficiency Foundation's Lunch and Learn series. Today, we will hear an overview of ataxia-telangiectasia from Dr. Howard Lederman of Johns Hopkins Medicine. My name is Emma Mertens, and I'm the Program Manager of Community Health at the Immune Deficiency Foundation. On behalf of the Foundation, we thank you for tuning in. Today's program is one of many virtual education opportunities available in our 2023 programmatic lineup. We recognize that through the provision of timely, comprehensive, and accessible information, we can improve the diagnosis, treatment, and quality of life of individuals affected by primary immunodeficiency. We appreciate you being a part of this journey. Before we get started, I would like to share a few tech pointers to keep in mind for today's program. This afternoon, we are using the Zoom webinar feature, and attendees should be able to see the slides and hear the presenter and host speak. Attendees will not be able to activate their video camera or their microphone. There will be the opportunity for questions after the presentation. You are welcome to submit any questions you have for Dr. Lederman as you think of them throughout the session. We kindly ask that questions are relevant to today's topic. Please type them once in the Q&A box in the control panel on your screen. Please do not include any personal health information, as all questions will be anonymous and read aloud. A brief disclaimer. Please remember the information presented during this meeting is not intended to be a substitute for medical advice, diagnosis, or treatment. We are here today as a trusted source and friend to provide you with information. Always seek the advice of your physician or other qualified health provider with questions concerning a medical condition. Never disregard professional medical advice or delay seeking it based on information presented during an educational event. Be sure to check out our website at www.primaryimmune.org, where you'll find resources, events, support services, and more. Everything is free to access and print. We can also help you find an immunologist or PI specialist in your area with the Clinician Finder. We also host educational programming and events, including lunch and learns and webinars, which cover a variety of topics facing the PI community. We also offer Get Connected groups, peer support, Ask IDF, and an annual conference. Applications are now open for the Immune Deficiency Foundation's Research Grant Program. This initiative supports well-defined research projects with a specified benefit for improving the treatment, health, disease management, or diagnosis of people with primary immunodeficiencies. Researchers may apply for up to $50,000 for 1 year towards their specific project. Applications are due by February 29, 2024. Visit the link at the bottom of this slide to apply and learn more. This meeting is made possible by our wonderful sponsors. It is due to their partnerships and contributions that we can provide programs like this for the PI community. Please join me in thanking today's sponsors: AstraZeneca, Accredo, Octapharma, Pharming Healthcare, Sumitomo Pharma, and X4 Pharmaceuticals. And now I am so pleased to introduce our presenter for today. Dr. Howard Lederman is a professor of pediatrics at Johns Hopkins University and serves as director of the Immunodeficiency Clinic, Pediatric Immunology Lab, and Ataxia-telangiectasia Clinical Center at Johns Hopkins Medicine. He also serves on the Immune Deficiency Foundation's Medical Advisory Committee. Welcome, Dr. Lederman, and thank you so much for joining us.
All right, thank you very much for having me. I really appreciate the support of the Immune Deficiency Foundation, both for making this Lunch and Learn webinar possible, but for all the things that you do for patients and all the things that you've done as patient advocates over many year period. So let me share my screen. All right, hopefully that's now working.
Yep, Looks great.
Okay. All right. So I'm going to preface this by saying that I think I have a very tough job today because the way I understand it, about a third of people are physicians, about a third of people on this call are parents, and there may be some number of teachers or therapists or other allied health providers. And trying to put together this talk with that kind of a diverse audience is not an easy task. But we'll see how we go, and I will end early so that there should be plenty of time for questions. So I'm going to talk about ataxia-telangiectasia, and we'll talk about what each of those words mean, but we'll just for now abbreviate it as AT. And just in the way of disclosures, I'll say that the AT Children's Project has supported the clinical center at Hopkins since 1995, and that I have some consulting arrangements with 2 different companies that are working on potential therapeutics for AT. I'm not going to talk about any of those as part of this talk today. I'm going to concentrate in 3 major areas. We're going to spend a little bit of time talking about what causes AT. And I'm going to then feature 3 different problems. One is the neurologic problems that occur. The other one is immunodeficiency and a predisposition to lung infections. The third one will be cancer. And at the end, I want to discuss a little bit of the issues that AT people have as they get into their 20s and 30s and beyond. A problem that I have to say we didn't used to have, but over the last 25 years, because we've done a much better job of managing immunodeficiency, lung disease, and cancer, we have a large number of people with AT that are living into their 20s, 30s, 40s, and beyond. So I want to start by just emphasizing the fact that AT is a systemic disease. So this disease affects virtually every organ system in the body. And this slide is actually incomplete, but it'll just give you kind of a general sense of that. So ataxia refers to a movement, let's say when you're walking and kind of are wobbling or looking a little bit like you're walking drunk, or having trouble keeping your trunk in a stable position, or if you're trying to reach for a pencil, that you don't immediately go and grab that pencil, but there is some tremor or extraneous movement that makes it difficult. And I'll show you a picture of the telangiectasia, but these are kind of corkscrew, very prominent blood vessels on the white part of the eye that are not present early on in life, but usually develop after the time of the diagnosis. And those are 2 features that give this disease its name. In addition to those 2 problems, AT causes immunodeficiency of a variety of severity. It causes a predisposition for people to get lung disease above and beyond the problems that are due to immunodeficiency. It leads to a very high lifetime risk for cancer, as much as 30%. Even among people under the age of about 30. So that's a spectacularly high incidence. It causes problems with sexual maturation. It leads to a predisposition to develop certain kinds of diabetes. And as you'll see as we go on, there are more body systems involved. But I'm going to concentrate for today on the neurologic degeneration, on the lung infections and immunodeficiency, and on the cancer. These are the telangiectasia that are seen in people with AT. I'll say that most of the time these don't start appearing until kids are 3, 4, 5, and these days they are not always, but frequently diagnosed before the telangiectasia appear. This is strictly a cosmetic issue. It does not interfere with vision, and it's not prognostic in any way. Sometimes kids will have these blood vessels and they look like their eyes are bloodshot. And pediatricians or other providers or teachers may wonder if the kids are getting enough sleep or they're waking up with bloodshot eyes because they're not sleeping enough. And they sometimes get confused with pink eye or conjunctivitis. And sometimes people prescribe antibiotics, which don't work. So these are dilated blood vessels. I'll say that sometimes the same kind of dilated blood vessel can occur in other parts of the body. And the place that we see them most often actually are in older patients, where we will sometimes see these on an MRI of the brain. And for the most part, they don't cause symptoms no matter where they are. AT is caused by mutations or misspellings of a gene called ATM. And this is inherited in an autosomal recessive fashion. So what that means is that if you look at this diagram, this is a child who has AT. And this child had a mother and a father, each of whom had one ATM gene that was misspelled and one ATM gene that was spelled correctly. And the first thing for me to say and to emphasize is that if you have one ATM gene, which is completely normal, for the most part, that's enough ATM function to make the cells completely normal. So people who are carriers of AT do not have neurologic problems. They don't have lung problems. They don't have a predisposition to diabetes. The only real disease predisposition is that women who are carriers have an increased risk of breast cancer. There is statistically a small increase in the risk of pancreatic cancer, but it's so small that nobody thinks that it should have any extra kind of screening tests. But for women, being a carrier should mean that you get mammograms at an earlier age, and you may start getting breast MRIs early on in life also. And I want to emphasize that because if you have a child who is diagnosed with AT, screening other people in the family for carrier status is worthwhile, both to provide genetic counseling about the risk that somebody could have a child of their own with AT, but also particularly important for the females, for the women in that family, because carrier women deserve some extra screening for the possibility of breast cancer. So if a carrier mother and a carrier father get together, there is 1 chance in 4 that they will have a child who has AT. There's 1 chance in 4 they will have a child in whom both of the ATM genes are spelled completely normally, and 2 chances out of 4 that they will have a child that will be a carrier. And I want to emphasize that this risk, 1 chance in 4 of having a child with AT, is for each individual pregnancy. In other words, if a couple has 1 child with AT, it does not mean that the next 3 pregnancies that they have will not lead to somebody with AT. This is like flipping a coin or rolling dice. And you can sometimes get heads 3 times in a row, or you can roll dice and get the number 4 multiple times in a row. Now, ATM is a very complicated gene, and for lots of reasons, I'm not going to go into all the things that the ATM protein, the product of the ATM gene. I'm not going to talk about all the things that the ATM protein can do, but I want to emphasize 2 things. The first is that if cells are in the process of just living and growing, sometimes cells will have a break in their DNA or their genetic information. There are certain kinds of cells, lymphocytes in particular, that break their DNA and have to put it back together multiple times in order to generate a normal, adult, mature lymphocyte. And ATM is essential for helping the cell to put those broken pieces of DNA back together. So if you're missing the ATM protein, cells have a tendency to have breaks in their DNA, which don't get repaired. That can lead to problems in those cells, and it causes immunodeficiency. And it can also lead to an increased risk for cancers, particularly leukemias and lymphomas, which are cancers of white blood cells. The other main role of the ATM is that it helps cells to react and to respond to different kinds of metabolic stress. So the easiest way for me to describe this is for you to think about a fireplace. If you have a fireplace and you're getting heat and light from that fireplace, those are all good things, but fires in a fireplace also generate some smoke and soot that you don't want. And the fireplace gets rid of those things by having a flue and sending them up through the chimney. Cells don't have fires, but they burn glucose or sugar as a way of generating energy. And they have some byproducts which can be just as toxic as smoke and soot. And there are a variety of ways that the cells respond to those toxic byproducts. And many of them depend on activation by the ATM protein. So in particular, cells that are very metabolically active have some problems surviving if they don't have ATM around. And this may be a mechanism which particularly affects the Purkinje cell in the brain, which is the cell that causes most of the mischief and most of the problem neurologically in this disease. This slide is only to show you how complex the cellular functions are of ATM. This slide is a little bit old, but it just gives you an idea of that when ATM is activated, either by a broken piece of DNA or by some of those cellular byproducts, that it directly or indirectly will activate literally hundreds of other proteins in the cell. And you can imagine, because ATM is so central to the way that cells work, that if there is no ATM protein, or the ATM protein does not work, that it will have lots and lots of effects on the cells. All right, now I want to start a little bit more detailed discussion now of the clinical problems that we see in AT. And the most prominent of those is a problem with the nervous system, or the way the brain works, a term that we would call neurodegeneration, meaning that over time, there is some brain function which gets worse. And typically what we see is that kids are pretty normal in the first year of life. Sometimes a 6 or 9 month old, at least in retrospect, a parent will say, gee, when I had them sitting, they were doing a lot of wobbling. It was hard for them to sit in a stable position. But the most apparent obvious abnormality neurologically usually is around the age of a year, when kids start to walk. And for those of you who are parents, you may remember that when your kids start walking, they're always kind of wobbly, and they can look like they're drunk, and they will fall multiple times. But over a relatively short period of time of weeks to a month or two, that unstable walking becomes quite fluid. And that happens because Purkinje cells in the cerebellum, a part of the brain that's in the very back lower part of the brain, kind of act like the way you program your cell phone in order to call your spouse or your friend without dialing all the numbers. You put in a program, and then you press one button, and it automatically calls your husband or wife. And when you're learning how to walk, it requires the coordination of lots and lots of neurons. And the Purkinje cells figure out what the program is. And then when you start to walk, the Purkinje cells just operate that program without you thinking about it. In AT, the Purkinje cells don't work in a normal way, and there aren't as many of them as in children without AT. And it's difficult for them to have this very fluid, easy walking. Now, over the next 4 to 5 years, there does not seem to be much change in the neurologic function of kids. In fact, in a lot of ways, it will get better. So a 1-year-old may be barely able to walk, and at 18 months or 2 years, they can start climbing upstairs. And that's because other parts of the brain outside of the cerebellum are maturing. And we see exactly the same thing happen in people with AT. So they tend to get better, although for the most part, they don't look completely normal. But they continue to get better up until somewhere around kindergarten or first grade. And usually around that time, when they get into school, there starts to be some noticeable deterioration in function. It's hard to predict what that will be. I would say that many children at that age start having more difficulty with walking. They may look a little bit more wobbly. If they're in school and they're walking down the hall, it may take only a little bump from another child in the hall in order to send them into a fall. Their speech may become more difficult to understand. They may start to develop some ataxia, or what probably in lay language would look like a tremor when trying to reach for something. If they are trying to write their name, what should be straight lines of letters may start looking kind of wavy and erratic. And they will at some point start developing difficulty with their way their eyes move. So they may normally, when you look from left to right, your eyes move from left to right and your head moves from left to right. And in AT, there's frequently a discoordination between eye movement and head movement. And the eyes, instead of moving in a very smooth way, will move in kind of a jerky way. That deterioration will get worse over the next 10 years or so. And it can get worse in all kinds of ways. So it could be that the walking will be most affected and other parts of the brain function are not, or it could be that everything gets worse about the same kind of a tempo. And I would say by the time most kids with AT are around 10 years old, they are going to need a wheelchair, at least for some parts of the day. So they may need a wheelchair only if they're walking long distances, or maybe they need a wheelchair in the school corridor just as a way of keeping them safe from falling. And then something very unusual happens that we really can't explain at all, which is that somewhere between the ages of 13, 14, 15, for the most part, the worsening neurologic symptoms either slow down or in most cases they completely stop. And beyond the age of 14 or 15, there is usually very little to no continued neurodegeneration. And before I move off of this slide, I want to just emphasize the fact that there is no deterioration of intellectual ability at any age. That may not always be completely apparent with schoolwork. So school depends a lot on the ability to read, and the eye movement problems make it more difficult for kids to get information by reading, but they're able to get information from listening. And sometimes the output is difficult because their speech may be garbled and it's hard for them to speak, or it may be difficult for them to write. But if they have an aide who can help them and take dictation, it's very clear that intellectual ability per se does not deteriorate with age and AT. And I think that's a really important thing that everybody should keep in mind. This is just a graph to show you what I talked about, which is that if you look at neurologic function, and let's say that a perfect score is up around 100, that kids, when they're diagnosed, are always a little bit wobbly or have some abnormalities, at least by the age of a year or two, but they're relatively stable. And then there's this period of decline up until around age 13, 14, 15. And after that, things are relatively stable. The most apparent effects of AT are all in the cerebellum, this back part of the brain, and particularly in Purkinje cells, which are the kind of telephone operators that make connections among different nerve cells operating motor function. And that's happening in the cerebellum, and over time, the cerebellum usually gets a little bit smaller. And I'll just say again, the size of the cerebellum is not a good predictor about how any AT patient either is or will be doing in the future. This is a good time for me to mention that as kids get older, this is usually after the age of 10, one of the things that they can have difficulty with is chewing and swallowing safely. That's because the same way that the cerebellum helps you to walk or to speak or helps your eyes to move, it also is important in having you breathe separately from swallowing, so that you're not swallowing while you're trying to take a breath in. And when you have trouble with that coordination, sometimes when you eat or drink, some of what you eat or drink, instead of just going down the windpipe or the esophagus into the stomach, will go down the airway or the windpipe, the trachea, and end up in the lungs. And I'm going to just kind of conclude this section by saying that we really still don't understand what causes the neurodegeneration. And there's some theories, but we really don't have solid evidence yet. And that's been the biggest impediment in developing drugs to slow down or stop the neurodegeneration. So we don't understand why the Purkinje cell is specifically the target. We don't understand why neurologic function seems to stabilize after, I think here I said 18 years, but it's probably even earlier, 14 or 15. And we really don't know how to slow or stop the neurodegeneration. All right, now this is the Immune Deficiency Foundation, and I certainly need to talk about the immunologic problems in AT. And I think I already mentioned that when you have AT, there are difficulties in lymphocyte development, because lymphocyte development requires breaking DNA and putting it back together. And when you don't have the AT protein, ATM, that's a difficult process for cells. So some patients have problems making immunoglobulin or antibodies. That's not all patients by any means, but probably about 30 to maybe 40% of patients with AT will have some problem with antibodies. And the good news is that if you have a child who has problems making antibodies, we have very good ways of treating it, primarily by giving gamma globulin, either intravenously with what's called IVIG, or under the skin with subcutaneous or under the skin infusions of gamma globulin. People with AT also have low lymphocyte counts, especially low T cell counts. And you might predict that they would have some of the same problems that HIV infected patients have with low T cell counts. But for a variety of reasons, they don't seem to be major issues for most kids with AT. So I would say, in general, people with AT have an increased risk of getting sinus infections, bronchitis, and pneumonia because of their antibody problems. And those are problems that largely can be prevented or managed by giving gamma globulin. And people with AT have increased problems compared to the general population with warts and with another kind of chronic viral infection of the skin called molluscum contagiosum. And those are pretty much the only real problems with having low T cell numbers. So I think I've already talked about most of this. I'll just mention one other issue, which is that people with AT can sometimes have a particularly difficult time handling the live virus in the rubella part of the MMR, measles, mumps, rubella vaccine. And they can end up with some chronic, at least partial replication of virus in the skin, which can cause a chronic inflammation in the skin that can sometimes be very difficult to manage. And because of that, whenever we have an AT patient who is diagnosed early in life, one of the things that we do is recommend that they never get the measles, mumps, rubella vaccine. So in terms of managing the immunodeficiency, we try to boost immunity with standard childhood vaccines. and that would include the use of COVID vaccines and the flu vaccine. If children or adults with AT are unable to make antibody to vaccines, then we give them gamma globulin or IgG therapy. We try to decrease their exposure to infections, particularly infections that may affect the lungs, by being sure that all the people that are in the household, all the kind of frequent contacts, are immunized with COVID vaccine and flu vaccine. In general, we don't think that there's any reason for people with AT to be homeschooled or be masking in school. And in fact, I think there's lots of reasons that shouldn't happen. I think they really need socialization, which does not come when you're sitting in front of a computer terminal and you are having virtual school. And in people who already have difficulty making themselves understood because they have some slurred speech, putting a mask on only makes it more difficult. And we tend to be a little bit more liberal in the use of antibiotics when kids get some persistent respiratory tract symptoms. That certainly doesn't mean that every time a child gets a cold that they ought to get antibiotics. But if they get a cold and the symptoms are lingering or not getting better and you are out at 10 days or so, then we tend to be a little bit more liberal about using antibiotics. And we try to minimize the risk of food and fluid going down the windpipe by having kids always drink from a closed cup with a straw so that their head and face is in a kind of a neutral position. And we don't like them to be chugging from a Coke bottle by tilting their head backwards. And sometimes with the help of either a local physician or a lung specialist, we may do some things to help them clear mucus from the lungs. Now, overall, I would say that the two major causes of death in people with AT are lung disease and cancer. And there's another group of about 20% of lots of kind of unusual issues. But I think it's really lung disease and cancer that are the big issues and the things that we do our best to try to prevent. The causes of lung disease are kind of complicated. So one is that people can have more problems with infection because of immunodeficiency. And I've already spoken about that. It's the reason that we may put some people on gamma globulin. It's the reason that we tend to use antibiotics a little bit more liberally than normal. And it's a reason that we I lost my train of thought. And it's a reason that we emphasize vaccines for other members of the family. Okay. In terms of the brain, as I've said, one of the issues is that because of the neurologic problems, kids may aspirate a little bit more than normal. And so we have lots of ways of trying to teach them how to eat and drink in a safer way. And also ways to help them clear mucus or anything else that may get down the airway, which is something that's difficult to do because, again, a cerebellar function is to help you take a big, deep breath and cough and clear your lungs. And for some AT patients, that's difficult. But there are a number of different kinds of therapies that we can use to help with it. There are a small number of people with AT who develop inflammation. So this is not infection. It's more like an autoimmune disease of the lung. And the main issue here is recognizing it so that it can be treated. And then the last cause of lung disease in AT is actually due to treatment for cancer. And just to say that chemotherapy can sometimes cause some direct damage to lungs. And there are certain kinds of chemotherapy that we try to stay away from because of it. All right. I mentioned at the beginning that cancer is much more common among people with AT than in the normal population or the rest of the population. So our cohort, which is now over 500 patients, 17% of them had a total of 90 cancers. And the average age for getting cancer was probably somewhere around 16. So if you look at the rate of cancer under the age of 20, so the rate of cancer in children, among people with AT, it's almost 12%, which is more than 30-fold higher than in the general population. And the majority of them ended up dying either from a cancer or a complication. But I want to emphasize that a lot of this is historical information. And particularly in the last 5 to 10 years, we have figured out ways that are very effective for treating many of the kinds of leukemias and lymphomas, and to treat them to the point where they are just completely cured without causing a lot of complications from those therapies. So I think that 67% figure is not likely to apply to most AT patients in the 2020s. Certainly not those with leukemias and lymphomas. And the overall comment I'd make about cancer in an AT patient is that treating cancer in an AT patient is significantly more complicated and a little bit trickier than treating cancer in somebody without AT. And my general advice is that most of those people can be handled by a local oncologist, but they should get in touch with somebody who specializes and has had experience treating AT patients with cancer, so that they get a little bit more specific information about those problems. And I want to emphasize one other thing. So under the age of 18, almost all the cancers that we see are leukemias or lymphomas. So you see here leukemias, Hodgkin's lymphoma, non-Hodgkin's lymphoma, and just a small number of people with cancers in what we call solid organs. In adults with AT, and we're seeing more and more people live to that time period, more than half of the cancers are solid tumors. So these are cancers of the esophagus, the stomach, the small bowel, the liver, or melanoma, so kind of skin cancer. And the important thing here is that the symptoms in a 25-year-old, when a person goes to a doctor with a specific group of symptoms in a 25-year-old, they will rarely think about cancer, whereas the same symptoms in a 65-year-old would probably lead the doctor to think about cancer much earlier. So this is an issue probably for us to try to educate doctors, but also something that parents can stay on top of, which is if their children have symptoms and there don't seem to be obvious answers, they can always get in touch with us at the AT Clinical Center, and we can see if we can help direct their local doctors to think about other possible explanations. Now, I want to just mention now that we have more and more people with AT living into adulthood. And by adulthood, I mean 20s, 30s, 40s. And as that happens, we are seeing more and more problems that we hadn't anticipated and that we hadn't seen in younger people. So first of all, there's a very high rate of inflammation in the liver, and actually a significant number of people in their 20s and 30s that develop cirrhosis, even though they're not been using alcohol. I think I mentioned before that there's a predisposition to develop a certain kind of diabetes, and also a predisposition to develop very high lipids like cholesterol and triglycerides. And I think that group of problems, the liver, inflammation, type 2 diabetes, and hyperlipidemia, are all caused by something going on that's inflammatory in the liver. And we're working really hard to try to understand what that is, but we don't at this point. There are more and more problems with what I would just call extreme fatigue. And there are lots and lots of reasons why somebody with AT can become fatigued as they get older. But I'm just going to mention that we have that. we certainly have more and more people as they get older that have difficulty with nutrition. So it's difficult for people with AT as they get older to be able to eat and drink enough to maintain their weight. And as their weight goes down, that leads to some loss of muscle and weakness. And I'll just say that that weakness will make the neurologic problems worse. We've talked about the fact that there's a different spectrum of cancers in older people with AT. And the last thing I want to mention is that as people with AT finish high school, we really have a terrible kind of a social problem for them. So while they're in school, they have things to do. They have some peer group, they have some friends. When high school ends, it's been very difficult for some people to figure out what to do with their lives. And this obviously is different from family to family and child to child. But I would just say that for those of you who have patients or children with AT, that as soon as they get into high school, you should be starting to think about what's going to happen at the end of high school. And you should be looking for help from either local societies or from the school guidance counselor, and see if there are some kind of work-life kinds of programs or ways of getting job training in high school that will give them something to do outside of the house when high school ends. So I want to just end this talk by saying that taking care of people with AT really requires a village. And these are all the people that have worked with us at one time or another on at the AT Clinical Center and trying to take care of children. And I want to just highlight Sharon McGrath Morrow, who's right now at the Children's Hospital of Philadelphia. Tom Crawford, who's a neurologist who's been with us from the very beginning. Maureen Leftengreif, who's an expert on speech and language pathology, and is really the person that identified aspiration as being a big problem in these patients. Dr. Sharma, who's at St. Jude's, who's an oncologist, who's kind of a recent addition to our group and is learning a lot about cancer and cancer management in AT patients. Jennifer Wright, who's our clinic coordinator. And then all the people at the AT Children's Project, but particularly Brad Marcus, who's the founder, and Jennifer Thornton, who's the executive director. And just to reiterate what I think I said at the beginning, a special thanks to the AT Children's Project, both for serving as a general source of information and support for people with AT, but also for supporting our clinical center. And I think that'll give some time for questions. I'm going to stop sharing my screen.
Wonderful. Well, thank you so much, Dr. Lederman. That was excellent. All right. So we now have some time set aside for Q&A. If you would like to ask a question, please feel free to enter it in the Zoom control screen in the box at the bottom of your screen. We have a couple in there already that we'll go ahead and get started with. All right, so one of these questions you definitely covered in your topic, asking how AT is a type of primary immunodeficiency. So I'm going to amend this question a little bit. Is AT a neurological condition with PI comorbidities, or would you consider it a PI with neurological comorbidities? Would you initially be diagnosed with AT by a neurologist or an immunologist?
All right, so the first way for me to answer that is to emphasize again that the loss of the ATM protein causes problems in lots of body systems. And I would say that the neurologic problems and the immunologic problems, or the immunodeficiency, are two separate, distinct features of AT. So the immunodeficiency does not cause the neurologic damage, and the neurologic damage does not cause the immunodeficiency. They're separate. Now, as far as how AT gets diagnosed, I would say that there's two ways. So these days, a significant number of people with AT are diagnosed in the first months of life because there's a newborn screen for an immunodeficiency called severe combined immunodeficiency. And that's part of the newborn screen that every newborn in the United States gets. And people with AT will frequently come up abnormal on that screen. And when they get referred to an immunologist, they pretty quickly figure out that they don't have severe combined immunodeficiency, which is what that test is supposed to find. And then the immunologist will usually do some genetic testing, and that will lead to the diagnosis of AT. And frequently it leads to the diagnosis of AT before there's any immunodeficiency and before there's any neurologic problem. For a child who doesn't get picked up by that abnormal newborn screen called the TREC test, then for the most part, they get diagnosed by a neurologist when they start having that wobbliness of walking that doesn't get better.
Thank you, Dr. Lederman. All right, next question. This individual says, I'm curious about breast cancer screening for women who carry the ATM pathogenic variant. Is there any additional X-ray sensitivity concern about radiation from repeated mammograms? And is this part of a risk-benefit calculation for those individuals?
Okay, so people who are carriers for AT do not have any radiation sensitivity. So they don't have any extra risk for radiation exposure from a mammogram than anyone else. And mammograms use an extraordinarily tiny amount of radiation. So I would say the answer is that I'm not concerned at all about the risk of a mammogram. And breast MRIs, which are also used frequently for monitoring high-risk patients, don't have any X-ray at all.
Wonderful, thank you. All right, this individual asks, does this disease tend to present more in boys or girls, or is it evenly distributed by sex?
It's completely evenly distributed by sex. And it seems to be pretty evenly distributed by race and ethnicity as well. Mm-hmm. There don't seem to be any specific racial or ethnic groups, with the exception that there are a few very inbred populations where lots of cousins are marrying cousins and marrying cousins, where for whatever reason, AT got into that population, and there seem to be a lot of people. So there's a high rate among Mennonites. There's a high rate of in certain population in Turkey. There was a high rate among Bedouins in Israel. But those are kind of very specific areas where there's a lot of intermarriage. And just by accident, probably somebody had AT and then passed it on.
Thank you. All right, next question. Will AT always be evident and diagnosed in early infancy or childhood, or do some people not get diagnosed until later in life? Is there such a thing as late onset AT that is identified in later adulthood?
Yeah. So this is getting to be a very interesting area for research and for clinical care. So the typical patient with AT has a misspelling of the gene that completely kills the gene. Or I guess the other way to say it is they have a misspelling in both of their ATM genes so that they make no ATM and they have no ATM function. There are a small number of people with AT who have one misspelling or one mutation, which may reduce the amount of ATM protein or reduce the function of that ATM protein by, let's say, 95%. So they have a little smidgen of ATM function. And those people can sometimes either have mild symptoms that don't progress until they're in their 40s or 50s, or maybe have typical symptoms, but very slow progression. And those are called, among other ways, they call them variant AT. And we probably, over time, are going to recognize more of those people. So as an example, we saw a patient a few years ago who was in his 60s, who had been working as a chemical engineer very successfully in a company, has a whole group of patents, drove to work every day, and sometime in his 50s, started having problems with coordination to the point that he was no longer able to drive by himself. And neurologists couldn't quite figure out what was going on and did a gene test and found out that he was one of those people that had a little bit of ATM function, about 5%, and a very atypical case. So that happens. It's pretty unusual, but it happens, and it may not be as unusual as we think.
Thank you, Dr. Lederman. We have a couple of folks in the Q&A asking about upcoming research studies and clinical trials for AT.
So I would say the one trial that I know that should be starting sometime in the next 6 months is a trial that is supported by Accredo. And I'll say that I'm a consultant for that company, so just to disclose that. What they have is a process by which they can put a kind of a steroid called dexamethasone into red blood cells and infuse those red blood cells into people with AT, and the red blood cells will slowly release the drug. So the way this actually works is that kids come in the clinic, they have an IV put in, they have about 2 ounces of blood taken out. It goes into a machine that mixes the red cells with the drug and puts the drug inside. And they ran a very large, very complicated, multi-center, multi-country trial, which ended about a little more than a year ago, which suggested that that treatment might delay the time at which children stopped walking. And I say might because it didn't reach the statistical milestones that both the company and the FDA had set out. So it suggests that it may be helpful, but there's not proof yet. And so there will be another trial, hopefully opening sometime in the late spring or early summer in the United States and in a few centers in Europe for children, I think between the ages of either 4 to 9 or 5 to 10, somewhere in that vicinity, who are still walking. So that's the one big trial that I know of that is going to start soon. There are a number of trials in different places in the world with small groups of patients, and most of them without a control group, that are just looking to see if they can find some whiff that another drug may be helpful. And I'd say none of those are so far been very encouraging. Oh,
Thank you.
And there are at least 3 companies now that are trying to work on gene therapy for AT as a way of trying to repair the defective gene in the brain, in the nerve cells. One of those has 2 children enrolled. That's at Boston Children's Harvard Medical School. And it's too early to know whether anything's happening, and they're not enrolling any more children right now.
Okay, good to know. Thank you so much. All right, I think we have time for one more question. So we'll end on this one. Do you think that a cure, given that there are these ongoing and newly starting clinical trials, is possible for AT eventually?
I certainly think that a cure is possible eventually, but I think this disease is going to be a tough one. It's probably going to be easier to cure the immunodeficiency because we can take cells from the blood and we can put them in the laboratory and we can fix the gene and grow them and put them back in. That's a much harder thing to do in the brain. Those cells don't grow after you're born, and you can't just go into the brain and scoop out a bunch of cells and then put them back somehow. So this is going to be difficult, but I certainly am optimistic.
Well, that's wonderful to hear. All right, everybody. Well, thank you so much for your engagement and your participation in the Q&A. We really appreciate it. I think that's going to wrap up the Q&A portion of this program.
All right, thank you again for having me.
Yeah, thank you so much, Dr. Lederman. This was great. It was a pleasure having you join us, and we really appreciate your time today. Thank you so much.
All right, thank you.
All right, if your question was not addressed during the program, please go online and submit your question to Ask IDF. Visit www.primaryimmune.org/ask-IDF, or you can also give us a call at that 800 number on your screen. Our resource navigator will personally connect with you to answer your question or direct you to appropriate resources. We also encourage you to check out our library of resources and YouTube page to find more videos and educational materials. As we head into the end of the year, our educational events are still in full swing here at the Immune Deficiency Foundation, and we hope to see you at one of our upcoming programs. We have 2 more webinars in 2023. One will be next Thursday covering mast cell activation disorder, and our final webinar of the year will take place on December 6th, and we will be discussing COVID's impact on the PI community. Visit www.primaryimmune.org/events to register and learn more. Registration is now open for the 2024 PI conference, which we will be hosting in person at the Sheridan Grand Riverwalk, Chicago from June 20th to 22nd. Visit primaryimmune.org/conference to register. And scholarships are available to attend our 2024 PI conference. In order to be eligible, individuals must be diagnosed with the PI, but we definitely encourage you to apply. Visit the conference landing page to apply by January 5th, 2024, and you can also email events@primaryimmune.org for more information. And again, we want to thank our wonderful sponsors for their generous support of our educational programming and community services. Thank you so much, everyone, for your participation this afternoon. And a huge thank you again to Dr. Lederman for this great information. We hope to see you at one of our many upcoming events this fall and into the new year. Take care and have a wonderful rest of your day.